Thank you and good morning. I'm going to talk you through the key recommendations from this perinatal confidential inquiry into stillbirth and neonatal deaths in twin pregnancy. So the first key recommendations have been identified from existing guidance. We haven't taken every single recommendation in each chapter, but distilled the core ones that will make a real difference to mothers and babies. So the first of these is to fully implement the national guidance, and this requires resource for care of women with multiple pregnancies. We particularly found the core and multidisciplinary team of specialists within a dedicated multiple pregnancy clinic, including a specialist midwife and sonographer, will make a difference to mothers and babies. That discussion with parents of the risks associated with twin pregnancy before 24 weeks and a high-quality ultrasound service with dedicated expertise in multiple pregnancy is key. The second national guidance is the BAPM clinical framework for perinatal management of extreme preterm birth, and in particular, the involvement of parents in the joint decision-making around resuscitation, stabilisation, and ongoing care. I'm just going to talk you through a vignette where implementation of this guidance unquestionably would have made a difference to these parents. A primiparous woman with an ICSI-DCDA pregnancy was admitted to a delivery suite at 23 weeks of pregnancy with worsening abdominal discomfort and a brown PV loss. She was reviewed by the obstetric registrar and examination confirmed her to be in labour. The parents were informed that their babies were likely to be born too early in the pregnancy and so resuscitation would not be recommended. This was reinforced as an appropriate plan following a telephone call for advice with a neonatal registrar. Condolences were offered and the parents advised that the babies may be born with signs of life, but that comfort care would be the most appropriate in this situation. At no point did the parents have a balanced, objective, face-to-face conversation or review with a senior neonatologist. The decision-making was led by the obstetric neonatal registrars, despite there being sufficient time to facilitate this essential conversation. Both babies were born within hours, in good condition and at an appropriate weight for their gestation. They remained with their parents and died a few hours later. The next key set of national guidance that already exists that needs to be implemented is the National Bereavement Care Pathway for parents of twins experiencing pregnancy and one or more baby loss. That a high-quality pathological examination of the placenta and the baby, including ensuring that the pathologist is provided with a complete clinical history. And review of the perinatal death using National Perinatal Mortality Review Tool, and early engagement with parents in the process with the offer of a follow-up appointment once the review is completed, as this happened in so few cases. To improve communication, both verbal, written and electronic throughout the care pathway. This action is for commissioners, academic health science networks, clinical directors, heads of midwifery and maternity safety champions, but you too can make a difference. This second vignette that I'm going to talk you through is another demonstration of where implementation of this guidance would have made a difference to this mother's care. A woman missed fetal medicine and community midwifery appointments during the antenatal care of her DCDA twins. An intrauterine fetal death of twin 2 was identified at 23 plus 6 weeks gestation, and an in utero transfer was arranged for the birth of twin 1 due to her gestation. Safeguarding concerns were identified but were inadequately communicated to the unit where she was transferred. She gave birth at 24 weeks gestation. Although a bereavement midwife was present at the time of birth, there was no ongoing bereavement care or follow-up arrangement. In addition, there were issues with the death certificate and registration of the death with no acknowledgement of the death of twin 2 on the certificate. Despite significant safeguarding issues, there was a lack of communication between her care providers. And there was no evidence of follow-up care, community midwifery support, or local review. You can make a difference. The next set of recommendations are new ones, and these are key ones that we believe would make a difference and improve the care of mothers and babies. The first one is around a lead specialist obstetrician from the core team providing each woman with a 16-week antenatal check to assess and explain the general and specific risks of her pregnancy. And this action is for professional organisations, NICE clinical directors, heads of midwifery and healthcare professionals. The next new recommendations are around prompt review by a specialist obstetrician of all women attending maternity triage and upon admission in labour and throughout labour, and in particular to ensure that all clinical staff working in maternity triage or emergency assessment are able to recognise the warning signs of preterm labour and twin-to-twin transfusion syndrome, to provide a clear plan for monitoring in labour, mode of birth and when referral is required, particularly in extremely preterm labour, with senior review at least daily, and when necessary to ensure prompt review by a senior neonatologist. And this action is for professional organisations, NICE clinical directors, heads of midwifery, maternity safety champions and healthcare professionals. This is a vignette where recognition of the severity of this woman's condition would have potentially made a difference to her outcome. She was diagnosed with MCDA twins at 12 weeks gestation. She was appropriately counselled as to the risks of complications, including twin-to-twin transfusion, and had appropriately timed ultrasound assessments to screen for this potential complication. All scans were carried out by a midwife sonographer. At 22+2, she referred to maternity assessment with a 3-day history of reduced fetal movements and increasing abdominal distension. She was reassured there were no complications following an antenatal clinical examination, but no ultrasound scan, and discharged home. 3 days later, she re-presented following 2 interim phone calls, reporting reduced fetal movements and that her abdomen was rapidly increasing in size. Again, she was assessed clinically by a specialist obstetrician in training and a senior midwife, reassured and discharged home. No ultrasound assessment of light core volumes was performed nor arranged for the next working day. At 23 weeks gestation, she presented with ruptured membranes and both twins had died in utero. You can make a difference. The last recommendations are around following spontaneous birth of twin 1 at less than 24 weeks, and to consider delaying the birth of the surviving second twin if there are no contraindications, such as infection, fetal compromise, bleeding, or chorioamniopathy. Counsel parents prior to the birth of twin 1 regarding the possible option of a delayed birth of twin 2, including the maternal risks, as well as the risk of twin 2 being born in the extremes of prematurity. This action is for professional organisations, NICE clinical directors, heads of midwifery and research funders. I don't want to leave you on a negative note, and there were examples of really outstanding care. This is a woman who was diagnosed with MCDA twins at 13 weeks. A preliminary diagnosis of a lethal abnormality in one of the twins was later confirmed at 20 weeks. She was sensitively counselled by an obstetric consultant who provided excellent continuity throughout her pregnancy. There were additional supportive sessions that involved the wider MDT, including consultant neonatologist and a bereavement midwife, who ensured that the parents' wishes were clearly documented in anticipation of the birth of their babies. She self-referred to the maternity unit at nearly 34 weeks with SHROM and vaginal bleeding, and her babies arrived by emergency section in the hour following admission, and as expected, one of the twins died shortly after birth. The surviving twin progressed well, and the parents were able to view their baby's improvement via a camera in the neonatal unit while the mother remained on delivery suite. In line with parental wishes, which had been identified during the antenatal counselling sessions, both babies spent time together following birth. Mother and the surviving twin were discharged home. So you can make a difference, and thank you for all you do.